I want to invite up to the stage our 4 keynote panel participants. Senator Pete Kelly, Chairman of the Senate Finance Committee. Becky Hultberg, CEO of ASHNHA. Albert Fogle, the Employee Benefits Consultant at Northrim Benefits, and also, not speaking in this capacity, but I think it's notable, the President of the Alaska Health Underwriters Association. And Noah Laufer, the Managing Physician or the boss or the god or the chief doc or whatever it is at Medical Park Family Care. Not sure, what title do you go by formally, right? You got a lot of them. Grab a seat. Thank you, everyone. Let's give them a round of applause. Good. Senator, why don't you sit here? So this panel is very much a manifestation, I think, of what we're trying to achieve, getting different groups together and chatting. I will tell you, we only have a few rules in terms of speakers and speaking at State of Reform. One of them is that you can only speak 2 years in a row. You can't speak 3. Of all of our events that we've hosted, I think maybe Becky has spoken on more than maybe almost every one of us. This is our 6th year. This might be your 4th time speaking. So we make an exception in some cases. Becky, so let me start with you. What is it about this time that is different? It's the same kind of question I asked Karen earlier, but maybe more specifically, why do you think there's so much more anxiety now? Is it just the fiscal situation, or are other things dawning on leaders in Alaska healthcare that make this time different?
DJ, I don't think it's just the fiscal situation. I mean, I think the fiscal situation is a big part of the change that we see on the horizon. It's one of the factors precipitating change. But I think if you look farther, kind of deep into healthcare, you have to understand what your big payers are doing. One of those big payers, especially from a hospital standpoint, is Medicare. Medicare is driving dramatic change in how services are paid for. Medicare is moving toward value-based payments, and they are just very transparent about that. So I think you have to start looking at the change on the hospital side from Medicare, and then the change that's coming on the physician side from Medicare with the new MACRA physician compensation structure. Then you layer on top of that some of the changes happening in the lower 48 around value-based purchasing, and then add the state's fiscal situation into the mix, which is driving changes both in employer groups and in public payers. And I think you really have a recipe for change that really is different this time.
Yeah. So let me just sort of push back on that a little bit, Becky. Medicare is such a small part of the overall line of business for many providers here.
It may be small for some providers, but for hospitals it is very significant. And it is going to be a growing part of the payer mix as you look at the baby boomers who are aging into Medicare. So as hospitals, we do not have the choice to say we're not going to take Medicare patients. That is such a huge part of our business and of our moral and ethical obligation to serve the community. So I think from the hospital side, Medicare is critical. For some other payers, perhaps it is a smaller portion of their business. But I think what we've seen in the past is that Medicare makes changes, other payers adopt those changes. So it's not just Medicare as a payer, it is Medicare as a real leader in payment reform that is different this time.
Yeah. So, you know, Albert, Becky said a lot of very smart things. One of the things that she said, I think one of the words was moral. And I wonder, do you see from where you sit as a broker, dealing with plans, dealing with employers, trying to identify and measure ROI out of a healthcare spend? It's sometimes very difficult. Right. Does this system look immoral to you? If we assume that everybody's acting above board, everyone's acting in the best possible, most moral way, and we cast no aspersions on any one individual actor or organization, is the system nevertheless antithetical to our social values?
I think that the system in entirety is broken. And you have a lot of different individuals taking on their own silo and making sure that they're protecting their own business but not looking to their next door neighbor and saying, hey, how can we collaborate? How can we partner together so that we make the whole system better for an individual? At the end of the day, anyone in the healthcare industry, your customer is that person that's walking through the ER, through your doctor's office, that's seeking help or care. And I don't think that the healthcare system as a whole is doing the best job that they can to take care of that customer.
Yeah, tell me, I know you have a multiple personal and professional experiences in healthcare. Tell me more about what you think about that, because that is a pretty, I know what's behind it, and it's a pretty loaded statement, right? That sometimes providers aren't thinking about their clients or their patients first, right? Is that what you're getting at?
There are some providers in this community in Alaska that are excellent, that they will take care of you. Their staffs are going to make sure that they go the extra mile to make sure that you're handled, you're taken care of, and that they'll call the insurance companies, they'll call other providers, they'll coordinate with everybody. But there are other providers that are in this community that simply, all you are to them is a dollar sign, and that's all they want to see, and bring you through the door and out the other end and collect their payment. I mean, I'm a little harsh there, but at the end of the day, I don't think that we have enough providers on the side that care, as opposed to the ones that are trying to just advance maybe their practices or their own career.
So Noah, you get the task of representing all physicians on this panel right now. Let me sort of let me take some of what Albert said and ask it a little differently. In healthcare everywhere, not just Alaska, everywhere healthcare is Lake Wobegon, where everyone is above average. So maybe what Albert's saying is not so really revolutionary. Maybe he's just saying actually there's an above average and a below average, right? I mean, and I know you think that from our personal conversations, but isn't that just sort of a revolutionary statement in and of itself in the medical community, not just providers, that there are below average providers?
I don't know it's revolutionary. I think we all are all aware of that. We just don't want to talk about it.
Yeah.
Right.
But, you know, obviously we're aware of it. There's the old joke, you know, what do you call the guy who graduates last in his medical school class? You know, doctor.
What do you call him?
Doctor.
Doctor, yeah.
There are a lot of old jokes. And I would actually agree that, you know, we're not getting the outcomes out of healthcare that we want, but it's not intentional. It's not an evil people. It's just a system that has evolved, and it's 20% of the world's largest economy ever. It's a super rich ecosystem, and from my point of view as a doc, but also the owner of or one of the owners of a small business, I'm covered with parasites. I can't even tell you. I mean, fleas and ticks and biting flies, and I mean, the things I have to take care of so that I can do the right thing for my patients are tremendous.
Oh yeah.
And when you talk about, it comes down to these really fundamental things. How provocative and raw do you want me to be? I mean,
You were invited here
so,
for a reason,
okay.
Noah.
I'll tell you, I was at dinner with the restaurant owner, and I'll say somebody who has a PhD in liberalism, and they were saying, you know, healthcare is a right. And I'm like, well, then I'm a slave, because if I won't provide it to you when you want it, where you want it, then I'm denying you a right. And so since we're at the restaurant, I said, how about I go down out on the street and I'll get a couple guys who are truly hungry. There are plenty of them in Anchorage on the street, homeless, cold, hungry. And we come in and you just give them the meal of their lives. That seems like a pretty fundamental, right? No, you know, this is a small business. We can't do that. How about I just want a glass of fresh water? No. How about just a minute in your restroom to go to the bathroom somewhere in privacy and in dignity? No. But if you stumble out in front of a truck and get hit, you have a right to $1 million of trauma care and care the rest of your life. And I would ask, does any country on the planet have the capacity to provide unlimited care to all of their population? It's ridiculous. And we don't have the guts to ask that kind of thing. So in the meantime, we have a super complex ecosystem, 20% of a huge economy, and because there's so much money there, it just gets filled by everybody who sees a niche that can come in and, in the name of savings or the name of federal compliance or regulatory stuff or whatever, you know, make money
let me jump
and not
in there.
contribute to CAL. Let me say one thing really quick.
You get more time. Hold on.
Last month.
Hold that. I mean, you got more time coming. Let me ask Senator Kelly a question here on this, because it strikes me that when stakeholders with great intention see the world differently and have emotion behind it, that it becomes extraordinarily difficult to find good policy. That it's hard to get the stakeholders in a room together. And yet, if you don't get the stakeholders in the room together, the legislature has to keep writing checks to cover Medicaid. What's it like chairing the Finance Committee right now when these kinds of conversations come to you in often very disparate and emotional ways? How do you piece this all together to say, let's write a check for more Alaska Medicaid services?
If I could for just a moment, play off of what he was saying, and that is that motivated self-interest in a free market should take care of the needs of its citizenry. There are some exceptions, there's no question about it. But for some reason, we have singled out some industries that they are not allowed to participate in a free market that operates by motivated self-interest. If there are physicians out there that are not offering good service, that are so wrapped up in their bottom line that they don't provide a level of care that we would consider kind of an entry level of care, then we would hope that the system would put them out of business, just like it would put out of business that restaurateur who might treat their people the same way. People will make decisions, if they are informed, in a free market in such a way that their dollars that they vote with go from one provider to the other based on the service that they provide. So you're asking me a very specific question, and I'm giving you a huge global response. My apologies, but I think that huge global response is something that has to be addressed. We're holding them, the healthcare providers, to rules that we don't hold most participants in a free economy. Mm-hmm. And frankly, I could go on about that as well, because in fact, we're holding too many businesses. Healthcare hasn't been that singled out. There are a lot of businesses out there that have been singled out that they can't operate in a free society without constant oversight by some government agency. So I think that's the starting point of our problem. Then when you take what's happened recently in Washington, D.C., particularly with President Obama, you know, the RPMs have risen substantially over the last few years, and it's you're now expected to operate in a system that's almost designed to go broke, so that a larger political goal can be achieved. And I think we're putting the providers who could be such a huge asset for us, we're throwing a wet blanket on them and not allowing them to achieve and produce in a way that would be beneficial to all of us. So forgive me for going off on that.
No, it's fine.
So what was your original question? I'll answer that.
I think that's a good one. And I don't want to, you know, sometimes I ask these questions teeing up easy stuff and hope that you'll go into more interesting stuff. Albert, I know you were waving your hand. Did you want to respond?
Yeah, I would just say, you know, healthcare is sort of that industry that everyone likes to say, oh, the free market will take care of it. But there's not free market principles working in the healthcare marketplace. If you can't see what prices are for services that are readily available, just like you go in and buy a steak or a car or a house, you don't have those free market principles for people to take their dollars and shop them elsewhere, and to complicate the measure, where here in Alaska, where we have a smaller number of providers, especially in the specialty market, where they can actually shop around for their services.
Mm-hmm. So, Senator, let me ask you about this sort of policy question, which is related to transparency, not just of prices, but also of quality. It's hard to have a functioning free market, to Albert's point, if we don't know what things cost. And even if we know what they cost in one circumstance, I go to this was during the cost conversation earlier, maybe I go to a hospital and the hospital is part of my provider network and I know what that's going to cost, but maybe the anesthesiologist is not contracted with me or with my health plan, and so I get a $30,000 bill from the anesthesiologist in a balanced billing situation. That's a complicated situation that is difficult to make good market decisions on when I don't have pricing transparency. One of the things that's been discussed about at the Healthcare Commission and other places is an all-payer claims database that can see what people are getting paid. Is that a reasonable policy solution to address this transparency challenge?
I honestly don't know, and I would turn to people like you to advise me on that. Let me just say this too, that I'm not so naive as to think that we can just completely unfetter this industry that has been so heavily regulated for so many years and hope that everything would be fine tomorrow. I don't think it would. Yeah. It is a regulated industry, and as much as I don't like that it is over-regulated, again, I'm not so naive as to think that the answer is just poof, all regulation's gone, because it won't work. There are levels of regulation that we need for many industries. They're just hitting a home run back in Washington, D.C. and in the state of Alaska as well on the healthcare industry. Somehow you guys are free game. I hope again. I keep wandering off your questions. And
that's good. Becky, do you want to jump in?
Yeah, I was just gonna point out that I think there's truth on both sides of this, that we do need to find a way to allow the market to work more effectively in healthcare. But but it is difficult, and it is more difficult for the market to function effectively in healthcare for a lot of reasons. But we are at this, I think, at a point in our nation's history and in our state where we really need to make some decisions. How are we going to move forward? Are we going to move, dare I say it, towards single payer, or are we really going to allow the market to work more effectively? There are ways that I think we can make the market work more effectively, and it's really about aligning financial incentives. What are payers? What are the outcomes that we want? And generally in healthcare, the outcomes you want are high quality at a reasonable cost. And how are payers paying to get those outcomes? Because that's not what we've paid for in healthcare for a long time. And so I think as we consider these questions, I think it's important to think about, are we paying for what we want? Because it's really sort of frustrating, understandable, sort of frustrating. We have these, when these arguments are kind of on a moral, when arguments about cost go back to morality, because really that's going to look different for everybody. What is reasonable? What is fair? I mean, those are questions that is really hard to answer. But if we can align incentives so that providers are incentivized to deliver care that is high value, high quality, low cost, then we will see providers responding.
Let me ask you this sort of philosophical question. And I don't know that anyone has quite an answer or is willing to give me quite an answer. But what is the goal of our healthcare expenditure? What is the goal of our healthcare expenditure? Governor Kitzhaber, I think later today, will argue that the goal of our healthcare expenditure is paying for medical care delivery. And that maybe it should be things like health, which is kind of your incentive conversation. Does anyone think that the goal of our healthcare expenditure should be medical care delivery, or should it be health, or should it be something else? What should it be?
We're like operating here in this very theoretical space. It's really fun, but I'm not sure. I think obviously the goal, at least from my standpoint, should be population health. But a lot of what we pay for is not related to population health. It's related to acute episodic care. And so that is part of the problem, and it's part of our cost problem. We're going to be so much better off if we can look at, rather than looking at how are we going to, what's the appropriate rate for a provider to be paid for X, if we're looking at how do we avoid the next emergency room visit? How do we avoid the next hospitalization? How do we make sure that our population is healthy so that we, number one, have medical services available for the people who truly need them. But number two, we have people at an optimal health status, so we're not seeing, I looked at some emergency room data the other day. Over a 3-year time period, we had a person in the state, it was aggregated data in the state, who was in the emergency room 284 times. 284 times in 3 years. That person's not getting their needs met.
Yeah.
So how do we restructure this system so that we can meet that person's needs to avoid those kind of costs?
So let me ask you, Noah, the follow-on question to my theoretical philosophical dance, which is, if we think about that outcome, whatever the outcome is that we think we want, and we examine the industry and the workings and the economics of the industry, and we ask ourselves, how can we actually get there? I might posit, theoretically, that in Alaska, the unique nature of Alaska and the unique financing and economics of Alaska puts a greater responsibility on providers to be innovative than health plans or government. That government and health plans are probably the laggards, should be the laggards, maybe they're not. I think one can argue that they're not. But that really the responsibility for innovation should come from doctors and hospitals to propose models that align incentives. You're busy taking care of patients all day. What time do you have to think about that? Do you accept that responsibility? I know you, I think maybe you probably do. Dude, how do you have time to think about that stuff when you're dealing with strep throats and broken bones?
That's quite a question.
Yeah.
So where do I start? I'm a family doc. I'm a second-generation family doc. I've been in practice 15 years. I followed my father into family medicine, and I'm in the same practice that he was in. And the reason I did it is I saw they were all men at that point. Now we're not all men. I saw that they loved what they did, right? And what I would say is, a confusing thing about medicine worth understanding is the two economies. I operate in an altruism economy. When I see a patient, I've paid a lot of money to employ people, and Brandon, our administrator, to isolate me from the economic economy, and I'm in the altruism economy. I'm there with long-term relationships, relationship-based primary care, to impact people's health. If they smoke, I don't, jump on them and try and click boxes. I talk to them. In fact, the first thing I say is, God, you're here with bronchitis again. Do you want a lecture? And they're like, no, we're good.
Yeah.
If you're ready, tell me. Because over years, I have success that way, right? I care about health outcomes. And I do think about it a lot. So, where do you start? So, access to health insurance. It sounds good. It's not the same as having health insurance. Having health insurance, that's not the same as access to health care. Having health care is good. 15% of health outcomes are maybe related to health care. So having health care is not equivalent to being healthy. And so, it's a huge abstraction, and you have 20% of the world's largest economy. It's not about health. It's about making money. I have to say that, I just looked at a list of 21, it's on Becker's Hospital Review, 21 healthcare billionaires. 4 of them are from the Stryker family. They make prostheses. Billionaires. It's great. If I ever need a hip, maybe I would like a Stryker, but billionaires. Being healthy is a very different thing from spending a ton of money on healthcare. And it's not the same as access, and it's not the same as supporting, all of these industries that are feeding off of healthcare.
Yeah.
Private industries, state, the money is just crazy.
So, Senator, let me ask how you, I think my personal view is all of these points are valid. They're all coming from good intention, and they're all sort of like the blind men and women around the elephant in the room, interacting with healthcare in a very specific way that they understand and makes sense to them. But on the other side of the elephant, there's maybe a little different perspective that is also valid. How do you think through Medicaid expenditure, and to a lesser degree health policy, but Medicaid expenditure, when I'm sure this diversity of opinion presents itself as stakeholders, and you maybe have just as great a diversity in your caucus. You got a unanimous vote, if I recall correctly, on SB 74, which tremendous kudos to you for that. I just think that was I think that was tremendously impressive, given the context of Alaska, but also context nationally, so well done. How do you move your caucus members forward with the diversity of stakeholder voices in the context of a fiscal crisis to say, let's do something interesting and innovative with our Medicaid expenditure?
By the way, thank you for the kudos, but I have kudos Kevlar on, and it bounces off and goes right over to that woman right there, Heather, who works for me, Heather Shattuck, and she just did a marvelous job. We did reach out to a lot of different groups to determine what exactly should be in this Medicaid reform bill. If I were to come up with Medicaid reform by myself, probably no one in this room would like it, and I wouldn't like it after very long either, because I don't live and work in that world. So bringing many disparate groups together is the key to getting something like that accomplished. The legislature looked at Medicaid reform, and I'm just going to stick with Medicaid reform.
Sure.
I think you asked a broader question, but I'm going to avoid it somehow.
Take it wherever you want.
All right. Medicaid reform was an interesting problem that confronted us. I was in the legislature back years ago, and then was out for a while and then came back. But the point is that back in the 90s, we were dealing with Medicaid, and we were dealing with it at the budgetary level. And I've been on finance the whole time I've been in the legislature. And inevitably, what would happen every year is you'd be confronted with some kind of shortfall. We've almost always had a shortfall in our funding for the last 25 years or so. And the question that the finance co-chair would ask is, okay, what did Medicaid do this year? And it was always some horrendous increase. I remember way back when we were so thrilled that it was only like $30 or $40 million when we were dealing with a much smaller GF budget at the time. And I think it got up to 120 million one time, and it was not to overuse a phrase, but it was out of control. It really was. And so each legislature would look at the Medicaid problem in terms of the budget that they had in front of them, and the clear and present danger of the fiscal crisis of that year. They had to meet certain goals, certain reductions, and Medicaid was always standing in the way, because if you had a $120 million increase in Medicaid and somehow you had made the assertion that you were going to cut the legislature by $50 million, or the budget by $50 million, well, the first thing you had to do was cut $120 million to get to zero, to then find your $50 million cut. And so the people that tried to reform Medicaid all looked at it the wrong way. They looked at it exactly the way they were forced to look at it because of the time constraints and the budgetary constraints that faced them. They had to get something done that year. The problem was the real only way to do that was to reform users, not the system. Reduce the options list, reduce the eligibility to receive Medicaid, basically make fewer people who were asking for fewer services. It never worked. And thank goodness it never worked. I mean, I was one of the ones that proposed it back in the 90s, and I say, thank goodness it never worked, because it was the wrong way to look at things. What we did with this particular Medicaid reform is that we reformed the system. We really paid almost no attention to the value or the economic value or consequences of the user. We decided we were going to try to give them better service at some kind of rate that was more better service that was more reasonably delivered by the state, so that we could save money. So bottom line was, we weren't going to try to reform people, we were going to try to reform the system. The other thing that we found out was that the people who work in the system, you tend to kind of blame them for all the problems. And frankly, these are pretty hardworking, well-motivated people that had been doing the best they could with a messed up system. And so that was the next thing we did. We weren't going to reform people, and we weren't going to start blaming the department. As a result, we came up with reforms that I always say they were the kind of things that if you went to one of your constituents, they would say, aren't you doing that already? They seemed to be so self-explanatory, so obviously beneficial, you'd think we were doing them for years. But in fact, we hadn't done them for years because we never really got into reforming Medicaid. We were only reforming people. And so I think the results are we're going to have a better system. We're not going to know for a while. We've required reporting back to the legislature so that we can keep a track on what's happening and make sure they're meeting the obligations that they have to the legislature. And we can find out as the reports come back that maybe some of the things that we cooked up in our offices weren't the best ideas, and we'll have to reform them too. So I consider this the first step of reform, although it is all-encompassing. I am amazed at the size of this bill and the things that were done. By the way, if we're going to throw out some kudos, I do also want to throw out some kudos to the governor's people, because we incorporated some of what they were doing into our bill as well. It had mostly to do with fraud detection, or fraud prevention. We were more about fraud detection. So
there's a lot there.
We hope it's going to be good, and we're not done. We're going to continue reforming it. It's not going to be to the magnitude that we did, and it's going to be from the data that we get back from these reports, and from people like you. I know our phone is going to be ringing off the hook and saying, you know that thing you did? Well, that was the dumbest thing in the world. And then if we agree with you, we go back and try to reform it, given that we'll have support from the legislature.
So, Senator, I'm going to ask Albert a technical question here with legislative implications. Albert, I know, and it's no surprise to Senator Kelly that people have a diversity of opinion about the performance of the legislature in recent months. SB 74, 91, those were big bills. We also had a small reinsurance bill that as a broker, I know, and as president of the Alaska Health Underwriters Association, we're supportive of. If we are moving into sort of a more technical legislation period, where maybe the big reforms are done and maybe we'll let Medicaid expansion play out for a while and SB 74 get implemented. If we're moving into perhaps a smaller, more technical bill period, this 80th percentile rule that came up in that cost conversation earlier could be done administratively. It might also not take a legislative action, but could maybe have legislative wind in the sails through action. Do you think that this 80th percentile rule, which proponents would argue is good for consumers, helps ensure access to providers, particularly in subspecialties across the state, both rural and urban areas, but is also a floor against which costs cannot come any lower? Do you think it's time to repeal that administrative rule, or can we still find success with that in place?
I think in any solution that we're going to have for healthcare, we need to do something that's a bigger reform for the healthcare system in Alaska. If we wait for the federal government to come and tell us what to do, like the Affordable Care Act, you see what happens in the private sector. We're right back where we were in 2009 and 10, where we had skyrocketing premiums, out-of-pockets that were unattainable by the majority of the population. And so if we just do one little thing with 80th percentile, or we do a balanced billing legislation, or we say that we're going to reintroduce HMOs into Alaska, just one of those things is not going to change the trajectory for this unsustainable path that we're on. We have to do a large, comprehensive reform to our system, and it has to be an Alaska solution. And I think that the 1332 waiver that we're able to waive out of the Affordable Care Act, as long as we still abide by by the majority of their tenants, that's the way for Alaska to go, because we're a unique state. We have our own challenges and our own problems. Whether we admit it or not, we're probably near the very top, if not the highest healthcare costs in the world. And we need to do something about that, because I think we were talking about it in the last session, where 40% of Americans don't have $1,000 in their savings account. Mm-hmm. So how can they afford a $5,000 deductible, or now a $7,000 out of pocket? They just can't afford it. So we have to do something in Alaska where every stakeholder comes together, the insurance companies, the associations, the providers, the employers, the consumers. We all have to come together to form some sort of solution that's going to benefit all Alaskans. And yeah, it's gonna hurt probably everybody, but at least we're gonna do what's right for Alaska. And I think we have a governor that's actually on board to make these types of changes and wants to do what is right for Alaska. But we need everyone in this room to start putting their heads together and making a solution for Alaska.
I think, Becky, if the president of the Alaska Health Underwriters Association takes a pass on the opportunity to hit the 80th percentile rule, then maybe there's not going to be a lot of legislative action or administrative action on it. I want to ask you the same question, but let me ask you sort of another philosophical question, because you like them so much. And this question, I think, directs our solutions one way or another. Is the Alaska healthcare house on fire?
Yes.
I'm going to ask all of you.
It was
I'm
my
starting with
question.
Becky, but
We are playing nice in the sandbox together here. Is the healthcare house on fire? No, the healthcare house is not. I mean, nothing is on fire. Except our economy. And I think that is really part of what's driving change, as we talked about in the first question, is we have a fiscal situation that is really driving conversations that we haven't had before. And that's an okay thing. That is a good thing. But it's a little incendiary to say the healthcare house is on fire, so I'm not going to go there. But do we have problems we need to address? Absolutely. Are we having conversations we haven't had before? Absolutely. I think we need to start thinking about what are the venues where we can have all the parties sitting down at the table. That happened during the legislative process. It happens here at State of Reform. But outside of that, there really aren't a lot of opportunities where all of these people are together in a room having these kinds of conversations. Maybe we need to think about that. I think just I agree that our problems are big enough that we need to get together and we need to collectively identify how we're going to move forward. But I do think that there are some things changing, and that those changes that we think may be incremental, in fact, are the next step down a path toward transformation. So I don't want to discount the small incremental changes, because some of those small incremental changes are things we might not have talked about 5 years ago.
Mm-hmm. Noah, I want to give you an opportunity to answer the same question, Senator Kelly, as well. Do you feel like we are in a time when the Alaska healthcare house, metaphorical house, is on fire?
I think the healthcare industry is on fire across the country, and pronounced here. But the day-to-day practice of medicine, I'm going to keep practicing medicine.
Right.
And my share of the healthcare dollar is so small that if we could just get rid of a few parasites, that'd be great.
Yeah.
I'm very excited about some of the things we're doing. I'm a founder and board member in AIM, and I'm a board member of Pinnacle. We're doing coordinated care stuff. We're going to provide better care, and I think we're going to do it cheaper. That's fantastic. But, is that how? Well, the state's $3.5 billion a year in trouble. That's not all health care. There's lack of foresight. But some doctors will leave, some will quit. We will have a more anemic, bare bones health care system in Alaska, but I'm going to keep practicing. I love doing it.
Right.
Healthcare's, practicing medicine is great. Taking good care of people is great. Helping the community to be healthy, great.
Yeah.
I'm going to do that.
Angel, do we have another microphone that we can bring up for Noah? Senator Kelly, what do you think? I mean, you look at the healthcare system from a very particular perspective. Would you argue that it's on fire, or is that, to Becky's term, incendiary?
Let me just look at it not as someone from a particular perspective, but just as an Alaskan. Are there anybody here from Fairbanks? A couple of you? Okay. Come on, people. Oh, Karen. I didn't know you were here. Hi, Karen Purdue. You're going to think I'm pandering to you after my answer here. So I live in a town of less than 100,000 people. Have you seen our hospital? Oh my God, it's gorgeous. It's incredibly equipped. And that community is well served by that hospital. We have a clinic that I think is the largest clinic in the state. And then as I drive through Anchorage here, there's hospital this and hospital that and clinic this and clinic that. We've got healthcare folks and we've got it coming out our ears. We haven't figured out a good way to pay for it, and we have incredible professionals that are delivering it. So no, the healthcare isn't on fire in this state. We're doing just fine. We have some problems as far as getting our health taken care of. We're doing well. But we have some problems about delivery and money, but no, it's not on fire. And I think, frankly, not to poo-poo your question, but I can't help but think of, I remember I was in a third world country one time. As you were asking that question, this image was coming to my head. This woman lived out in this little tiny village, and she had a piece of blue tarp over her. It was kind of put up on these sticks that would kind of shift in the wind. And she had this huge pile of rocks out there. And she had bags, and she would take the rocks, and had a little hammer, and she would smack those rocks and bust them up into different sizes and put them in the bags and then sell them to the company for gravel or whatever. You think she had health care? Not even close. If you were to ask her, is health care on fire, she wouldn't even know what you're talking about, because her health care was you get sick, you die. So we're fine in that respect. We have the opportunity to make it a lot better, but I'm not going to complain about our health care.
I would say, our healthcare system is not on fire, but how we're paying for it is, and that's exactly right. But just like the state's budget crisis, where we could see years ago where we were headed for this apex, where the lines were going to cross, we're headed for that in healthcare. I work with employers every single day, and I see 20, 30, 40, 50, 60% increases in prices where people are already paying for a $5,000 deductible. They're paying well over $1,000 per employee, and it's costing $36,000 for $36,000 a year for a family. These prices are completely unsustainable. If you're in the public sector, you're sort of insulated away from these types of prices because your health plans are pretty generous, and I don't think that you're paying as much as you are. But for the private sector, some of these employers, especially the small employers, which is the engine of our economy, they're struggling. They can't hire that additional person. They can't make that additional investment in their business. And that's taking away from our economy that's already suffering.
You know, Albert, I have this sort of, I don't know if it's a theory, but just this worldview that to the extent that we think that individuals are health illiterate, as sometimes we say consumers don't really understand health very well, I would argue they're even much more health system illiterate.
Oh,
yeah. And you know, it turns out the people that run small businesses are actual people, right? Individuals. Right. Yet, to your point, I mean, they're paying these bills, they're not really getting engaged, forcing more accountability from their healthcare spend. I mean, employers, we have a lot of employers in the room because you guys are CEOs, but we don't have a lot of, construction CEO, construction worker, or an HR benefit. We got a couple HR benefit folks here, but there's a whole economy of people that you work with in small businesses and large businesses that are not deeply engaged in demanding more from their healthcare spend. And if those Chamber of Commerce businesses don't demand more, if they just keep writing the check, are we really going to see much in the way of transformation?
Yeah, but you're seeing it right now where employers are taking away the health plans from their employees on the private sector side. You're seeing that drawback already. I agree with you that there's not really a lot of engagement by the employer with their health plan dollar spend, but they're really becoming more and more aware of it and trying to do something about it. And all they're really doing is taking a lot more of the plan shifting from the employer to the employee. So instead of having a $1,000 deductible, they're moving to the $2,000, $3,000, $4,000, $5,000 deductible plans. Mm-hmm. It's all this cost shifting to the employees just to barely keep on to that health plan. And then I was talking to a business owner on Monday who his employees, a lot of them have child support, they have other sort of deductions that are already coming out, and they have the health insurance plan. And at the end of the day, there's hardly anything left over for them to live on. Yeah. So you go back to that 40% of Americans have less than $1,000 in their savings account. We're barely holding on to these health plans.
Yeah, we're getting short on time. I want to give everybody an opportunity to have a last word. And let me sort of frame this last question as going back to our convening panel conversation about wanting everyone to sort of talk through their interests. And I think we saw a little bit of the emotion from that meeting come out here today and earlier today. and I'll start with you, Albert, and work down to Senator Kelly last. If you were to speak for brokers and employers, and you wanted the healthcare system represented by the people, or in this room, to know one short elevator ride thing that they should know about employers and brokers, and the interest, the thing that you want them to know about your industry, what would that one thing be?
Speaking on behalf of employers and brokers, I would say that you really do need to become more engaged in your health plan, and you need to start treating your employees' population as you would treat your own health, as your own family. You need to take care of them and make sure that they're all doing the right thing and helping them through the healthcare system.
Great. Becky, what should the community know about Alaska hospitals and nursing homes?
I think fundamentally, it's important to know that hospitals are the place that anybody can go, regardless of ability to pay. That's federal law. But it's federal law through the Emergency Medical Treatment and Active Labor Act, but it's also really an obligation, I think, that our facilities feel to their communities. Our facilities are deeply engaged with their communities. Here in Anchorage, we have several of our hospitals involved in the issue of homelessness, in really helping to try to ensure that the homeless are not just are getting medical treatment, but also meeting even more basic needs. And I could list other projects that our hospitals are involved in. So we're here to stay. We have big bricks and mortar facilities that aren't going to move. So we are here to stay. We're invested. We're invested not just in the health of our community, but we're invested in the long-term health of our economy and our population. So we want to be good partners with our community. That requires lots of relationships with stakeholders, including our physician partners, including others in the community. So we're here for the long term, and we want to figure out how to make this work even better.
Noah, how about you? What should the community know about?
Does this work?
Hopefully, yeah.
Oh, good.
About practicing physicians.
I think you're turning it off on me. No.
I have a little clicker in my pocket.
I have a problem in that I could talk, forever about everything, and
Five-story elevator ride.
Right. I think something that needs to be said and needs to be understood is when you hear, this, I call it whining or resistance or anxiety coming from the medical community, which you do. We're a privileged class. We recognize that. It isn't really about financial issues. It's about fear that we are not going to be able to do what we love doing, or it will be done in some way that is perversely incentivized or morphed into the wrong thing. Again, I've said this before, but being a physician or a healthcare provider, it's not a transient, episode in my life. This is my calling. And I am profoundly offended and also scared by people who do not understand it, saying, oh, it just needs to be done differently, or it's that simple. And that really scares us, and it paralyzes us to the point that we can't cooperate.
Yeah.
So, you got to understand, it is a calling, it's a love, and frankly, I'll bet a lot of the people here who are not physicians, part of what they derive joyfully from their professional lives is that they are part of healthcare. And after all, what is that? What is healthcare? And
Senator Kelly, what should the community know about the complexities, the challenges of being the co-chair of the Senate Finance Committee?
Get great staff and everything seems to work out. The legislature wants better health care delivery in this state. There's no question about that. There's a level of politics that plays into these arguments sometimes that it's very difficult for outsiders to understand what the heck we're arguing about. As I said the last thing about how we don't have a health care problem, what was going through my mind is the kind of thing you need to know plays in all of this. And I want you to think of a foreboding voice on a commercial that I will face 2 years from now if I run for re-election. Senator Kelly says we don't have a health care problem. And they'll run a little piece of this clip, okay? And so those kinds of things play into it, and they don't allow people to make always the best decisions. And there's so many things. I had a conversation with someone who was running for office, and I told them, as you go into the Senate, what you need to know is that it's about relationships. It's far less about the math, it's far less about statutes and those kinds of things. And it's about the relationships that you can cultivate and keep. And always make sure that if you are going to stab someone, that the wounds are always in the front and not in the back. But just understand the legislature wants to fix things, but there are complexities to it that we could spend all day talking about it. And half of what I told you might stick, and the other half you'd say that doesn't make sense. So
Let's give him a round of applause. Senator Pete Kelly, co-chair of the Senate Finance Committee, Noah Laufer, family practice physician at Medical Park Family Care, Becky Hultberg, CEO of ASHNHA, and Albert Fogle, employee benefits consultant at Northrim, and also president of the Alaska Health Underwriters Association.